Great. Well, an official good evening to everyone, and thank you for joining us on this rather chilly evening. My name is Liza De Beer, and I'm the Digital Marketing Manager at HealthBridge, and I will be your host for this evening. I'm excited to be part of this webinar, as due to COVID-19, we've been approached by a number of our clients with questions around how they could better manage the business side of their practice. So we put together this webinar to answer some of these questions, and I'm hoping that at the end, you'll walk away with some really great tools and tips to truly help your practice thrive. It is now just past 7 p.m., and we are going to get going shortly. So if you haven't already, please take a few seconds to complete the poll on your screen. While we wait for a few more participants to join, I thought it might be of interest to give everyone a feel for the room. We currently have about 44 delegates who have joined us so far. However, we had over 120 registrations, of which 33% of you are psychologists and 27% general practitioners. Of the other specialities joining us tonight, we have pediatricians, dietitians, occupational therapists, speech therapists and audiologists, physiotherapists, biokineticists, family physicians, social workers, nurses, clinical technologists, chiropractors, podiatrists, psychiatrists, and we even have a student joining us tonight. So welcome everyone, and I hope ESCOM remains kind to you throughout the webinar. Great. Now I want to bring your attention to some general house rules. Number one, if you have a question, please feel free to send it using the Q&A feature. We love questions and we'll try to answer as many as we go. So as soon as you think of any, pop them through. The Q&A feature is usually found at the bottom of your screen, or for some people, it might be there at the top right-hand corner. Secondly, if after the webinar you would like someone to call you back, please email webinar@healthbridge.coza. Simply include your name and preferred contact number in the email, and if you have a specific question, you can include that too. Either way, we will call you back. And lastly, this is a CPD accredited webinar. Therefore, your entrance and exit is automatically recorded. If you would like to obtain your certificate of attendance, please ensure you stay for the full duration. You will receive your certificate hopefully by tomorrow, but definitely by Friday. However, if you have attended the full session and have not received your email by Monday, please email webinar@healthbridge.coza. Sometimes these emails do get stuck either through your server or in your junk, and I'm more than happy to sort that out for you. Great. Now that the admin is out the way, I'm just going to stop the poll. Let me just find the poll here. Cool. And now I'd like to introduce you to our speaker for the evening, Louis De Silva. Louis De Silva is the MD of HealthBridge. In addition to leading HealthBridge and ensuring that the company remains focused on helping medical professionals to provide good patient care and run good businesses, Louis is an amazing storyteller. In fact, Louis has been invited by a number of industry stakeholders to present on a range of topics, including the impact of a strained economy on healthcare patient behavior, trends impacting ICD-10 coding, the importance of context in data-driven insights, and the digitized doctor's room of the future, to name a few. And so it's at this point that I'd like to hand over to Louis so we can get the show on the road.
Thank you, Liza.
Welcome, Louis.
Welcome, everyone. Liza, I did pick up a little bit of internet instability, so you got your fingers crossed for ESCOM. I've got mine for AfriHost. Hopefully all goes well. If something does happen, maybe ping me even on my phone if something happens, but we should be good. Thank you so much to everybody for joining today, particularly on this cold night. As per Liza's great intro, we hope that today will be informative, that the hour will fly past really quickly, but more importantly, that you'll take home some real tangible action points for the business of your practice. I'm just going to share my screen quickly. There we go. Liza, if you can confirm that you're seeing it.
Perfect.
Great. Okay, so the high-level topics that we are going to be talking about today. Firstly, I'd like to show you some trends that we see at HealthBridge regarding patient encounters during this COVID time. The second point is really to talk about what those trends have in terms of an impact on your practices. And the third point is really then some practical and ethical steps that can be taken to address those potential impacts and sometimes threats. Those are really the three major areas we're going to cover. Liza, looks like your camera has come back.
Yeah, got success.
So let's go ahead. But before we do that, and sorry, there'll be a conclusion as well at the end. Before we go any further, thank you to those who did enter the poll. And Liza, can you show us what popped out?
Yes, so you should be seeing it on your screen now.
Thank you. So we've got 69% who have seen patient volumes drop over COVID. 6% of you have seen an increase in patient volumes. Wow, that'll be interesting to learn from. 19% no impact, volumes have stayed the same. 2 of you have got a practice that is still closed. And this is really great. 47% are using telehealth consults in one form or another, which is a very good trend. I suspect it's because we have many psychologists with us today, but we'll pick it up a bit later. Some of you are still thinking about it. Awesome, thank you. That gives us a good picture. And certainly these 2 questions are going to be 2 of the important themes that we're going to be covering today. So, let me get... Firstly, just a few trends that we've picked up over the COVID period, which we'd like to share with you. And the first one looks at patient volumes across all the disciplines that we serve. Many of you are here today, but it also includes really the combined mix of also the specialists, the pathology groups, radiology groups, really just an aggregated view of what the volumes have done over this period. And this data, as you see on the bottom left, is through our transaction data and is updated as late as the last Sunday, Sunday the 16th. We do weekly reviews of data collection and we cut off on the Sunday night. So this is the very freshest data that we see. And you'll see on each of these graphs, what we'll do is we'll go back 22 weeks, which was really the week before lockdown started. In fact, the week in which lockdown was announced. So you'll see the different markers there, lockdown. Then we had lockdown extension. We like to think of it as lockdown season 2 for those of us who have Netflix. Then we had level 4, level 3, and of course next week we'll see another marker as we roll the data through, which will be level 2. The little asterisks there represent the number of public holidays in that particular week. And that is a big driver in volumes we'll see just now. And particularly for week 16 or 16 weeks ago, where it was the end of April, beginning of March, I think it was Freedom Day and Workers' Day. In that week, in fact, we had 2 public holidays. That's the 2 stars. And lastly to mention is on the very right-hand side, of course, last week we had a public holiday as well. So we'd expect those volumes to be slightly on the decline compared to normal trends. Right, so that's the setup. And let's look at volumes across all disciplines. So you'll see that the week before, what we've done is we've benchmarked the volumes the week before lockdown came into action. So it was about mid-March, and so that becomes therefore the 100% index point, if you like. And what you can see is that as of that Thursday when lockdown became effective, already for that week, even pre-lockdown, volumes started decreasing, and then some really low volumes, particularly over lockdown season 1 and lockdown season 2. Of course, the 42% in 16 weeks ago is a little bit underrepresented because we had 2 public holidays there. But soon after that, level 4 took a nice little step up jump, and then level 3 If you just train your eye to the right of level 3, you'll see that the volume's picked up yet another notch. Interestingly, towards the end of certainly last week, the week before that, we started to see a decline in volumes after a bit of recuperation. And we'll talk about that just now in a bit more detail. And again, last week being the one public holiday, you've probably got to factor that back, and maybe that comes down to a 74, maybe even a 75% level, given that there was the Monday, I think it was a public holiday. So what we see then is really a gradual comeback after lockdown, and then a bit of a downturn over the last 2 to 3 weeks, which we need to explore a bit later today. So this is a great overall picture, but what's fascinating is that by discipline, a very different story is told, and I'd like to take you through that. And the first one is for general practitioners, and how do those volumes look when compared to those different milestones through lockdown. And this is what we see. Quite a significant drop as lockdown kicked in. Then we started to see a nice pickup. In fact, across all specialities, reaching 90% of volumes, I think outside of pathology, which has its own reasons, it was one of the strongest comebacks. But concerningly, there's been an ongoing decay over the last couple of weeks, something that we had forecast. Again, I want to discount the 64%, but certainly the 71% was a full week. And it'll be interesting to see what this week is, given that it's a full week again. So certainly the best comeback, but then continuous slippage as we move into the last few weeks of time. Optometry value is a very different story. Completely emaciated as soon as lockdown kicked in. And one can understand that because most optometries are in shopping malls. So really took a hard time. As soon as level 4 opened up and the malls or kicked in and the malls started opening up, a really nice recovery. And towards the end, also a bit of a drop, but we need to remember that these are volumes related to March of the year, and certainly for optometry, the volumes tend to start declining towards the end of the year or midpoint of the year as benefits run out and so on and so forth. So I think the really only thing we can deduce is clearly a real hard knock, but then a nice immediate jump back as soon as level 4 kicked in. Dental volumes. A similar pattern, but not to the same extent. So again, a very unique story. Really got knocked hard during lockdown. I guess nobody wanted to go and have a dentist pry into their mouths over that time. Then saw a good comeback in level 4. And right now, I think probably the strongest discipline, if you look at those numbers towards the end, 100%, 103%, 95, 92, related to that mid-March week. So seems to doing a lot better right now overall. Then since we have so many psychologists here today, I think the psychology volumes will be very interesting. And again, a very unique story, which I have a hunch as to why, and we'll talk about it a bit later. But certainly one of the most robust disciplines during lockdown. You can see those numbers, 70s, the 60s, the upper 60s. Certainly very robust, not yet fully recovered, but I think on average probably one of the stronger disciplines if one looks at over the time frame. There's a very important reason why the volumes were a lot more robust than other disciplines during those lockdown periods, and that comes down to the best adopters of telehealth, which really kept going over that period. And as I said, we'll unpack that in a bit more detail just now. Specialist volumes, and this is the collective term specialists. What do we see there? Started recovering after lockdown, but stagnated at the 70-odd%. This is a bit of a suitcase statement because it covers both what we call consulting and cutting specialists. So if you double click into surgeon volumes, certainly you see a different story. And you can see there that in fact the volumes never really recovered out of the 60s post level 3. A bit of a peak 13 weeks ago, maybe a bit of pent-up demand, but here really I think we all understand it's the daily trade-off that I was chatting to a CEO of one of the hospital groups just the other day. The first meeting every morning by hospital across the group is the trade-off. How many beds do we need to COVID versus how many others do we have capacity for to do our general surgeries and so on and so forth. And obviously the surgeons have been on the sharp end of that, given that many beds have had to be allocated to COVID-19. Plastic surgeon volumes are an interesting one. Sure, I don't know how these practitioners manage the business of their practice, because it is completely volatile, as you can see. Liza, am I still on? I can see
yes, you are. Yeah. You're still on.
Thank you. I just wanted to double check that I wasn't talking to myself for the last half an hour. So plastic surgeons, absolute volatility. You can see ups and downs, and sometimes 133%, 160%. My theory here, and it's a hunch, I do have a running friend who's a very prominent plastic surgeon in the area. He tells me it's mayhem. It's really making use of spare capacity, working closely with the hospital groups or the hospital in his area, and really trying to fit in patients as and when capacity becomes available. Very, very difficult to obviously manage a business and staff and everything else in a scenario like that. And then pathology volumes, I guess not a surprise, took a big knock as well over lockdown. And then the last couple of weeks really hit some peaks, 133%, 124%, and so on, of course, as the COVID tests kicked in, but starting to drop, I think, towards the next couple of weeks as we see the numbers decrease. So that kind of peak COVID period, the 7 weeks to, let's say, 3 weeks ago, high volumes there, in particular related to March. Radiology volumes, not yet recovered. Again, you can scan your eyes towards the kind of right-hand quarter. It seems like there was a little bit of an uptick. Maybe it's some chest X-rays also related to COVID, but still nowhere near overall the initial volumes in March. And then lastly, this is an interesting story. The anaesthetists. Now, one would think that they too would have reduced dramatically because of the number of surgeries reducing. But there's a bit of a counter-cyclical experience. You can see again towards the right-hand side, started kicking up into the 80s, and that's of course because they are critical in the ICU ventilator cases for COVID. And during that peak period, obviously, although in lieu of being part of operations, they were very much hands-on, and many of them still are in the ICU case. And I've got to share a great story. One of our colleagues, in fact, a fellow EXCO member, his mom-in-law was in the real bad state in ICU with a ventilator, and today she got discharged a couple of weeks. I think she spent something like 31 days in hospital. An elderly lady with comorbidities, but managed to pull through, which is just a great story and a reflection of the great healthcare system and healthcare providers we've got. A few other trends. So I mentioned virtual consults. If we look month on month, from January, February, March, certainly as you can see from April onwards, there was a big uptake, and the trend is certainly increasing, which is very heartening. I've got to say though, it is relative to the complete volume still very low, probably at best about 3% of collectively all the volumes we see. Although, as I mentioned, in different specialities, we see different take-ons, and certainly in the psychology area and psychiatry area in some cases, the volume uptakes are a lot better there. This is particularly interesting because I've been talking to a lot of hospital people lately, but a very senior executive in another hospital group I was talking to yesterday, and they're looking at this very seriously because in their experience in the UK, and probably by saying that I've given up who this hospital group is, they've seen in their hospitals there that pre-COVID teleconsults was at about 10% for family practitioners. During COVID, it jumped to 70%, and as the numbers have eased and stabilized, there's a new pattern, and they're seeing about 40% odd of consults have now locked into the virtual consult space, which is an interesting trend. and certainly consistent with the US as well. It remains to be seen what happens in our country. And then, as one can expect, certainly there was a hype of video consults initially, and then as lockdown eased, so the numbers went down. It's a bit of a confusing graph, but if you train your eye on the green bar, that's by day, and that's why you get the peaks up and peak downs, being the two low days being the Saturday and the Sunday. But if you follow that green line, you can see how in the thick of it, the April, May, the numbers were high, at least initially, and then as lockdown level 4 kicked in, the volume started subsiding going forward. Yeah, and the one maybe last thing at a very aggregated and confidential, obviously patient confidential level, counselling was certainly one of the highest reasons for virtual consults, which once again one can understand due to the heavy involvement of psychologists, but also for general practitioners. A lot of it are the pre-COVID testing and screening and questioning came to be there as well. I think on this chapter, really lastly, so what do we think is going to happen for particularly at least the rest of the year? And with our data modeling, what we believe is that overall volumes are unlikely to return for 2020 to the numbers that they were initially. And we estimate that it will land at about 85%. And certainly those graphs seem to be trending towards that. There's a bit of a concerning downturn of late. Last week we can't really make conclusions on, so this particular week will be very interesting. But overall, I think we can collectively, all of us, expect on average about 85% of pre-COVID levels. Why is that? Well, firstly, we're moving through the peak now, thank goodness. But the impact of that is that patients will still want to stay away from practices, don't want to go into a place where people are sick unless they really have to. The impact of that, of course, is that the high at-risk patients, particularly for general practitioners that take care of diabetic patients and hypertensive patients and so on, these patients will need to be proactively engaged with because they are the people that need the care, yet are the people at risk from a COVID perspective. And we will continue to see, and I'll talk to it later, that doctors and staff will continue to be, every now and again affected themselves personally. Another factor drawing into the modeling of the 85% is there will be and is already membership contraction. When we talk to some very senior people at some of the leading administrators, they are seeing the tendency towards scheme buy-downs. The initial estimate right up front was that they would see a contraction of about 4% of the medical aid market. I think it's likely to be worse, and I'll share with you why I think that is a bit later. And then, of course, we know towards the end of the year, which is as we hope, and it seems to be tracking, that COVID begins to ease off a bit, the seasonality, the medical seasonality hits the end of the year, either because of benefits running out or people, frankly, just not getting sick during holidays in December, or sometimes practices closing for the holiday. So this all combined leads us to believe that we should expect no more than 85% of volumes overall across this period. Yeah, so that's overall the summary of the trends, and I'd like to focus a little bit of time now just really talking about, well, if that's what we see, what does this mean for practices, and particularly the business of practices? So I've done an interesting calculation, and it's based on, as you see at the bottom there, the Council for Medical Schemes report, the latest one available, which is the 2018-2019. I then extrapolated that for this year in terms of the average medical inflation. And looking at those gaps that aren't making up the 100%, these gaps over here, understanding the total healthcare spend for general practitioners, specialists, dentists, and allieds, I did a calculation as to what do those gray lines, in other words, those unfilled capacities, equate to across the whole industry, the whole private healthcare industry, across all doctors, not just our clients, but extrapolated across the market. And the number's quite staggering. Over the last 21 weeks, doctors have been affected by 8.2 billion rand. That's how much revenue has been lost by you all collectively. Let's say 15, maybe 17,000 active doctors across those different disciplines across this period. quite a staggering number, which all of you have had to bear a portion of. And if one assumes that we are correct, that 85% will be the average from now, mid-August to December, then there's another 3.4 billion rand that will be lost between now and December. And so these numbers are very material at a revenue line for the business of practices in South African healthcare. And therefore, it's not surprising that we see articles like this where private healthcare sector is going to medical teams and say, guys, you may not have, you probably are sitting a bit flush in terms of your expenses. Your volumes will pick up. At least, share a bit of that money up front with us as a bit of a prepayment, because we are really battling to keep afloat during these tough times. And what are these shortfall drivers? Well, I think we know what they are. It's the lockdown. It's, as we mentioned before, patients scared to come back. An interesting point for many practices, the strict sanitization process slows down the patient throughput, depending on what kind of specialty you are. And of course, the hospital bed capacity planning has certainly up to now been a really big issue. It's very pleasing, and I think all of us are very grateful to see how the numbers are decreasing rapidly, and hope it stays like that, because that certainly will open up the bed capacity. Another implication is a very real risk of your bad debt increasing. And just, summary of some of the ugly stats we know. Unemployment now over the 30% for the first time. Just between February and April, 3 million people lost their jobs, and sadly 2/3 of that were women. And it's across the board. Even in our IT sector, a big company like Dimension Data had to cut 480 jobs of 1,500 odd people because of the tough times during COVID. And certainly the language we use at Healthbridge is we are navigating the COVID storm, but let's understand there will be a financial storm that we have to navigate for our clients and for ourselves at the end of the day. Liza, just quick check, you still hearing me?
Yes, still hearing you.
Awesome. Here's an interesting report. So TransUnion, they do a lot of credit risk reporting and management. They did a bit of a consumer research a while back, about a month ago. And one of the key questions they asked is, what bills and loans are you concerned about your ability to pay? And this was aimed at consumers, as I mentioned. And it's a great report, because not only does it give you an overall report, but it gives you by generation. And that allows you to think about, what your practice spread is of the different generations, be it the Gen Zs, the Millennials, Gen Xs, or Baby Boomers. But importantly, you'll see that medical bills came up as one of them, where people are concerned that given what's happened to them, be it they lost their jobs, or their spouse or partner lost their jobs, or they've been put on furlough, or they've had to go through a pay cut. Medical bills, 21% of the respondents were concerned about the ability to pay medical bills, and that changed slightly across the different generations, certainly highest on the baby boomer side. Then there's the risk of practices intermittently shutting down, and this for us as Healthbridge is very real. We track the transactions and the activity of each of our clients very carefully. And when we don't see activity, we phone and say, hey, doctor, kind of what's going on? And so this is a snapshot of our CRM system where we keep track of all our interactions with our clients. And it's probably small text, but you'll see at the bottom there that we've in fact had to add another subcategory, which is COVID-19. In other words, practice closed due to COVID-19. And of course, being frontline staff, invariably there is the risk, and we've seen quite a number of practices or doctors being infected or having to go into isolation and so on and so forth. And that again breaks the revenue pattern of a practice, at least for a couple of days. If it's just isolation, of course, if a doctor is ill or sometimes staff, that disrupts the flow, so on and so forth. And last and lots, I mentioned already the health risk and the stress for you as a healthcare practitioner is not lost on us. Over and above all this financial stress, I guess this is just a message from us at HealthBridge to say thank you. Thank you for being out there for us. Thank you for treating us and our family members. We certainly appreciate it. You are the heroes at the end of the day, putting yourselves at risk. Right. The last area of conversation is really, so we've seen the trends, we know the risks for practices, what can be done? How can practices inoculate their businesses against COVID-19? And so I'd like to present to you two vaccines. The good news is you don't have to wait until June next year or whatever it's going to be. I was very tempted to add in some memes with either Putin, the Russian president, on a bear charging forward with a massive syringe on his back. Some of you might have seen that meme. The other one being the vaccine with Smirnoff labeled on it. Obviously all of it poking fun at the Russian vaccines. But I can confirm that these two vaccines I'm going to present, firstly, are South African. They are fully tested and trialed. They are double-sided, double-blinded, double everything, and have proven to work. So the good news is you don't have to rely on the Russian vaccine, and you certainly don't have to wait until next year, June, to apply these vaccine levers to the business of your practice. And what are they? Well, very simply, the one is thinking carefully about how some of the revenues are recouped over this time. Of course, in an ethical way, in a way that's good for you, a way that's good for the patient, and a way that's good for the scheme. And then the other vaccine that to consider that I'd like to take you through is how to reduce or at least variabilize your costs during these periods of low volumes and therefore low revenues. And the remainder of the presentation is really going to be looking at these two levers that certainly are, we believe, within your means to and in your control to work on, despite the out of control volumes and speculation of what they may or may not be. So first, of course, recoup revenues. TeleHealth is definitely an opportunity over this current time, and you'll see later some strong testimonials that point to this. It addresses some key challenges. Firstly, patients not wanting to come back into practices. Of course, you can't have every patient encounter as a telehealth one, depending on your speciality, depending on the condition of the patients. But there's quite a high volume of visit types, if you think about it carefully, that actually could. So that certainly addresses that need. If one is on average going forward at 85% capacity, well, then there's spare capacity. So why not use it, even though it might be at a reduced rate in some cases. If you as a doctor are having to self-isolate because of some exposure you may have come across, well, guess what? At least like this, you can continue to see patients even though you're at home. And the other important thing is it offers flexible hours, both for you and for your patient. Right now, it's business unusual, and therefore even hours of consulting, I think has shown to be quite flexible. It's something that I want to do in my spare time with our big data warehouse, is to look at the spread of claims over time per day compared to maybe a couple of months ago. I think we'll see very different patterns at the moment. And then importantly is that there's a growing patient readiness to do telehealth. And this was done by research done by Philips last year, where in South Africa they found that 36% of healthcare professionals were prepared to use telehealth to interact with patients. 38% of patients were open to remote consults when it wasn't urgent, and 32% were open to communicating with fellow healthcare professionals over the time. The orange numbers are the average over a 15-country research. The light blue numbers are the South Africans. So you can see we're a little bit behind on each of those dimensions, but not significantly behind. So certainly the openness and the willingness to do both from, it seems, healthcare professionals and patients are there. When considering telehealth, however, there are some very important, what we call hygiene factors that we feel you should make sure, no matter what you use, is in place. The first one is it needs to tie into your practice workflow. It can't be this thing that hangs on the end. You've worked hard at setting up the practice workflow from when an appointment is made to how the paper and the file flows to the doctor, how things come back so to ensure that the claim is captured and is not lost, and so on and so forth. And what you don't want is that this additional telehealth area where you might be from home or at night or whatever doesn't tie into that, and then cracks in your workflow starts creating. So you need to ensure that it ties in very neatly to your practice workflow. The other one, the single click, not just for you, the doctor, really easy, but particularly for the patient. As soon as the patient has to download apps and log in and sign in and so on and so forth, that becomes scary, and the drop-off we've seen becomes really, really tangible. With that, however, of course, security. We've all read the horror stories of hackers breaking into Zoom sessions at Parliament and what they did and so on. You need to make sure that this is secure both for the good of your patient and the good of your own legal status at the end of the day. And then very importantly, auditability. Medical administrators, CEOs that I speak to, yeah, we like the telehealth that reaches our team's members, that's good. But sure, how do we know this thing really happened? How do we know this claim just wasn't sent? Where's the auditability? Which is a little bit of an emotional response, because in the end there should be documentation and a patient record. But making sure you've got auditability of that encounter when telehealth happens is absolutely critical, we believe, particularly from an administrator and a scheme perspective.
So Louis, telehealth seems to be quite a hot topic. I've got a question here. Regarding telehealth, what is the minimum time for a telehealth consultation in order to bill the patient or medical aid?
I'm not sure of the minimum time. I know that by default the rate is typically lower, although some schemes have said, hey, doctors, thank you for helping our patients over this time. We in fact are willing to pay you up to a face-to-face consult. I think the average time that we've seen is about 7 minutes for a teleconsult, but that is a bit skewed because sometimes it's just a call for a repeat script, which can be a very short, just how you doing, everything working, okay, and then it goes on.
So I suppose it's got to fit the purpose.
Yeah. So we're seeing an average of about 7 minutes. It does come at a reduced rates, but of course, given that it's spare capacity and that you can, let's say if your GP put 2 of those in a typical 15-minute slot on an average of 7 minutes, then you really come back to the same rate per hour, if you like.
Okay. And then you touched on sort of the billing of it. And so one question is, how can I be profitable using telehealth if the consultation fee is less than that of a face-to-face consult?
Yeah, it's a great point, and it's sometimes a heated discussion I land up in. The market has reacted completely differently and inconsistently, on 2 levels, both on the teleconsult rate and also you'll see later on reimbursement for PPEs. There is the spectrum from actually we're going to reduce the old 0130 telephone rate because we're scared that this is going to be abused and there's no auditability, to the other extreme, as I mentioned, where some schemes have said, you know what, doctor, thank you, and actually we're going to reimburse you at your current face-to-face rate because you're actually helping our members and their beneficiaries. So there is a broad spectrum between those 2 extremes. I think the thing to consider, the argument that is sometimes made by schemes is, well, your costs are less. But the reality is your costs are fixed costs. They're not going to go away because you're having to do a teleconsult either in your practice for the benefit of your patient or in the fact that you might be at home and you still have a practice out there. So that to me is a bit of a bogus argument. The one thing is, if it is true that what we are seeing that the average consult is faster, then from a volume perspective you could pick it up and that should somewhat compensate. But in these times, the one question is, how can I do it if it's profitable? But if you're not seeing any patients, well, then at least you can see some patients at some revenue, given the spare capacity that is there. And that's something that each practitioner will have to make. Certainly if you are at 100% levels face-to-face, then there's no point going for reduced consults and a telehealth. But if you have spare capacity where over that time the revenue would be zero, well then, somewhere between 50% to 100% of a face-to-face, depending on the scheme the member, the patient belongs to, is certainly worth it. It's really marginal. It becomes marginal revenue, marginal upside revenue, because it's the other option is zero over that time.
Awesome. Great. Thanks.
Cool. All right. So those are hygiene factors, and the way we like to think of it at HealthBridge is the workflow process is very important. How does the patient get communicated? How does the telehealth consult get confirmed? How do we make it easy for the patient, no matter whether they're on an Android phone, an iPhone, a laptop, to jump into the practice, into the consult? How afterwards does the bill get sent? How do reminders for that bill get sent? Because you can't necessarily collect as the person leaves your practice at the checkout counter. So these workflows and these messages, you need to find solutions that really, or have processes in place if you don't have a solution, that really ties in these workflows. Because otherwise, the net effect could be reduced bad debt or increased bad debt, and schemes starting to say, hey, look, how do I know this happened? So important things to keep in mind. Then over and above the hygiene factors, we feel there are two very important factors that you need to consider when doing telehealth. And number one is making sure that you are seamlessly able to take clinical notes, potentially through an electronic medical record, while seeing the patient. So that you're not stuck at home and having to jot down some notes because you don't have the patient's file in front of you. And then you need to remember that for these 5 patients you saw while at home, you need to go back and stick it into the right patient file the next day. So something that's always available no matter where you and the patient are is key. Something like this where you have a solution where you can document the patient encounter, and at the same time you are able to interact with the patient either just verbally or through video, becomes very, very powerful. And it becomes an integrated experience, not just for the patient, but for you as well. And the great news is that automatically your clinical notes are done. And in fact, the claim should automatically kick off out of this process as well. Important factor number 2 is the patient follow-up. That's always tricky, even when you have a face-to-face, to follow up with a patient. But these days, particularly with COVID, that becomes particularly important. And not just for COVID, but in fact it stretches through to a patient with a diabetes or whatnot. And so being able to have a list of the patients that you saw, where they are in the stage. So in this COVID case, are they in isolation? Are they waiting for the results? Were they maybe too early in testing? Where are we in the process? How do we track it? They have been tested positive. How are they recouping? Have their oxygen saturation levels dropped below a certain level, maybe after a week, and therefore they should be going back or going into hospital. It becomes very complex to manage, particularly when you are managing patients through telehealth and you've got these follow-ups or a progression of a disease or condition that you need to keep your eye on. So having a system that keeps track of that is, we feel, quite important as well when you adopt telehealth. So that was the first category, how to recoup revenues, is certainly with that spare capacity, albeit it may be a lower rating for some schemes. Telehealth can offer an opportunity to fill up that space. That's again good for the business of your practice, but good for patients as well. And the second important part, and slightly linked to it, is the reaching out to chronic patients. We've all seen the news. Just the other day there was a publication that said that over and above the reported COVID deaths, 17,000 more deaths than last year at this time have been reported. And some of these could well be because patients that typically would have needed care are not going to get care because they're scared of COVID or can't get there, and as a result are dying ultimately with other chronic conditions. I didn't show you the stats earlier, but if you look at the oncology volumes, that is a scary story because you can see how inconsistent those patient encounters have been over COVID, for example, just given the situation. So being able to have a solution where you can ask your system, for those patients that have got ICD-10 code XYZ, the diabetics, the hypertensives, whatever, that I haven't seen in 6 months, be it face-to-face or via telehealth. Let me send out a mailer or an SMS message to them that says, hey Louis, hope you're doing well over COVID. You're one of my very esteemed diabetic patients. Notice we haven't really met, or you haven't come to see me over the last while. You were due for your follow-up diabetic appointment 2 months ago, and in fact an additional HbA1c test. Really concerned about you. Please come see me. Alternatively, if you're a little bit worried about that, then you can also see me via a teleconsult, and we can just set up the path test and a follow-up call to see how you're tracking and whether the meds are still working. Things like that is just a beautiful spot of win-win-win. Win for the patient's health, win for the business of your practice, and ultimately win for the scheme, because if I don't get treated by you, the diabetic, I'm going to incur a whole bunch of other expenses for the scheme down the line and end up in hospital and who knows, amputations and everything else. So this is something that certainly I think is ethically good for the industry, that you can certainly jump on for your practice and really have a campaign out there to draw those patients that really need care back into your practice. And already some schemes are out of their own bat are saying, hey doctor, I know that times are tough. You know what, there's a couple of complicated patients that we really think should be seen by you. How can we work together to get those patients in? And in fact, opening up special benefit packages to make sure, because they know that these patients, if they're not treated by you, down the line are going to have serious complications and as a result, serious costs. Then maybe not so much recoup revenue, but recouping costs. PPEs can be claimed for. The first to come out was Discovery, probably about a month ago already. It's quite complicated because their billing systems haven't really caught up. So you claim now, you'll get paid later and so on. And there's a whole complicated table. But of late, talking to an IPA head, other schemes have been engaging with IPAs or heads of associations to help doctors recoup the cost of PPEs. Just like with the telehealth consult, it is a bit of a minefield. Every scheme has a different way of thinking about it. So how you apportion your 1 mask per day across the spread of patients representing different schemes becomes an interesting calculation. Of course, you've got gloves that are per patient, so that's a lot easier. But they all have their own different models, and certainly at HealthBridge, we work very closely with these schemes to make sure that our pricing structures and price points are correct and accurately reflect this to take away that complexity. But it is a bit of a minefield. But at the end of the day, there is a way to claim for that, and certainly that becomes quite an important cost item if you think of it on a monthly basis, particularly with the volumes reduced right now.
So Louis, I have some questions around billing and coding. So the first one is, I can't keep up with updates from medical aids about how much they'll pay for things like telehealth and PPEs. So I think the question is there an easy way for a medical professional to know what this is?
Awesome. That's a great question. You shouldn't have to know. You shouldn't have to worry. The practice management system that you use, if you are using a cloud system, or if you're subscribing to something like MedPrax, there is a weekly file that goes out with these prices updated on an ongoing basis. And so in the end, when you type in a 0130 for scheme XYZ, the right price as per the latest agreement should be automatically populated into your bill. if you're not subscribing to something like MedPrax or you're not using a cloud system, it becomes overwhelming for you to keep tabs on all this volatility. Normally there's a big update in January and things are stable. In a year like a COVID year like now, there's just so much movement. We have got a team dedicated to this on an ongoing basis. And we all take a deep sigh of relief every, I think, Sunday night when we release the new pricing with the changes that have been effected over the past week. So typically we tend to be maybe at most 7 days behind, not because ours, but because of us, but we rely on a third party to provide us with some pricing. It is enormously complicated. A price of a consult is not only different by discipline, as you know, but it is different by scheme, by plan, by option, and then there's the layer of, depending what contract you belong to, by scheme, by plan, by option, that could change as well. It is like a 7-dimensional cube of complexity. And so making sure that you subscribe to a system that provides you and takes that complexity away from you is very important. I don't think a practice on their own can manage the complexity right now, given the volatility of pricing.
Great. Then I don't know how well you know the specific code, and if you don't have an answer, I'll get one from our team and email this doctor. But they asked if you could kindly explain the episode fee code CGPEPI. No.
Can I call a friend?
Okay, yeah. No, I'll get an answer. I didn't think you would know that offhand.
I think we can pass it on to Dia. Dia is our product management specialist in the claiming area, and I'm sure she can answer that and we can pass it back to the doctor.
Okay, perfect. I've had somebody, okay, great. Then another question is, when doing a telehealth consult and charging the applicable fee, if a prescription is to be written, can the doctor also charge the fee for the prescription? So a consult and a prescription fee.
I think it is, yes. I think that is the one way that, in fact, the total patient episode gets somewhat, what's the right word, accounted for or replenished, if you like, is that, in fact, I know that in our clinical system, when there is a prescription and it's a virtual consult, that line automatically gets added for some schemes that will pay for both, yes. And so then the number actually comes pretty close up to the face-to-face consult, even with the reduced virtual consult.
Right. That's it.
All right, we've got 7 minutes left. Maybe let me just finish up and then certainly we'll take questions. We'll probably need another 5 minutes or so just to finish, if I remember correctly. Don't want to take more time than 8 o'clock. Given telehealth, the typical patients that are open to the concept of telehealth are typically your millennials and younger, and these people go online. They will go online to find you. And so ensuring that you've got a good online presence might well bring you new patients that you can supplement your practice and particularly along the lines of telehealth, the reasons I explained. So there's a lot of good documentation out there. We certainly provide that free of charge on our blog site. Just tips and tricks on how to ensure that you get into the Google ad space, that your practice gets ranked, and just basic kind of social media training, if you like, on how to get your practice out there, so that those people who are looking for practitioners, particularly on the telehealth side, will become aware of the services. In terms of reducing bad debt risk, there's one simple answer. Be like the pharmacy. Nobody walks out of a pharmacy without knowing exactly what the medical aid is going to pay or not pay, and nobody gets to open that little caged box with a cable tie until they're paid at the teller just before you leave the door. And the reality is it is not just through us, but everybody in the industry, all our competitors offer the ability to send claims in real time and therefore collect outstanding monies right there and there, in fact, before the patient leaves your practice. And that transaction is closed and you can move on. A very basic rule for collecting money is the longer it takes to collect or to follow up, the much less chance you have of collecting that money. And frankly, quite shockingly, if we look at the delay between the date of service to the date of submission for a claim, if we track a claim and we know when the date of service happened, and we look at the date of submission of the claim to the medical aid, particularly given that the real-time functionality there, it's a little bit disappointing, to be honest. This is what it looks like. So across our clients, general practitioners on average take 7 days from when they saw the patient to when they submit their claim. Specialists, 12 days. Dentists, 6. Optometrists, 5. Allieds, some of you psychologists out there, 15 days. When you could be sending it and getting the answer from the medical aid before the patient, by the time the patient gets back to your waiting room, that answer should be in the hands of the receptionist to collect that money. We have practices that do this very successfully. Unfortunately, as you can see by these numbers, not too many. And that just dramatically increases your bad debt risk. And particularly now where consumers, your patients, are really under financial duress, this really lays you open for bad debt in the next months to come. So I guess we appeal to you. Embrace these real-time technologies. Be like the pharmacy. The tools are there. Another way to reduce costs is to move to cloud. It's cheaper than your desktop software, your practice management software. If you look at the total cost of ownership, in the end, between the PCs you have to have, the software licenses, the backups you've got to run, maybe the insurance you've got to take because sometimes patient data can disappear, it's actually cheaper. It's safer than desktops. The reality is storing your data in the cloud these days is safer than the desktop that you leave behind in your practice. We've got cases of practices being broken into and PCs being stolen with all the patient records there, for example. And these days, it's fast. The internet is fast these days across most areas. And perhaps unintuitively, now is actually the perfect time to do this shift. If it's true that we're operating at subdued levels and maybe 85% on average, you and your practice staff have got time. This is a great time to do the changes, to move onto a platform that is cheaper to run, and that sets you up for the future, because this is the future. It's not if, it's when, and many practices have made that jump. To give you an idea, at HealthBridge, we are fortunate to have over 3,000 practices who have moved to cloud offerings over the last period. The other great thing about moving to cloud, and this ties in, Liza, to the question that was raised. When you're in cloud, when you log in the morning, the prices that were updated last night at 1 o'clock in the morning by the pricing fairies are there for you to use. There's no need to download or install or contact with somebody or get an email or whatever. It is always there. And so that helps you to be the most up-to-date with the latest industry trends. It also typically, these cloud solutions give you a marketplace of value adds that you can customize for your system, for your solution. So think of it like an app store on your phone. And when new things come up, you can easily subscribe to them and they just become part of your solution without any major hurdles that you have to overcome. I want to share with you some great examples of practices moving to cloud, and I'll go quickly. This was a practice, it's Dr. Lee. The graph in the middle is of particular interest. She shifted her practice to, her face-to-face contacts are now less than 50% of her total volumes. And this is what she had to say, and I'll leave out the HealthBridge word because this is not a HealthBridge push, this is a CPD presentation. So the TeleHealth solution works like a charm for me and my patients. It's tracking my Many problems it's tackling many problems that COVID-19 has brought with it, like reducing stress for patients as they don't have to come into the practice, not to mention the fact that it's cheaper and saves on petrol costs. It also saves in precious time too. They arrive and I arrive in an online appointment where we both need to. We get great picture quality, so we get to the focus of the appointment and we don't have to worry about the technology. One of the other things I enjoy is being able to work from home. This has helped my secretary too, as my system, my online system, she has as well. It's easy for her to book my appointments into the calendar, and the billing side of things is really easy for her too, being online. I like that TeleHealth can be used with any medical aid. It's robust and it just works. I'm a Mac girl, so the fact that the system works and not just on Android for the Android crowd impresses me. There's a lot of negativity circulating lately, but having access to TeleHealth has in some way kept me positive about my own business. I can just keep doing what I need to do to run my business. Even in the future, I will definitely keep on using TeleHealth. This technology gives me more flexibility, as I often thought about how I could work from home more. When I think of the big picture possibilities, it's fulfilling for me to consider the opportunities for rural populations. This could allow them to access medical care and avoid the cost of travel too. Great message from Dr. Lee. Another one from Dr. Kathra. TeleHealth is really easy to use. We were shown in only a few minutes, and just a few hours later we were testing with our first appointments. I love that it's easy for my patients to use as well. It's simple as clicking on a link on their SMS or email. A new page opens in their browser and we're in the appointment. No hassles with permissions or setup. I can definitely see myself using this service in the future too. It's been a great help since the arrival of COVID-19, but it will be useful for me in other ways too. I can be anywhere in the world on business or holiday and still look after my chronic patients who need me. So yeah, I think some good examples of why TeleHealth is good. I'm going to go a little bit quickly because I realize we're over time. Another extension to that, of course, is to digitize your electronic patient records, to use an EMR. It removes the patient files. It saves costs because those filing cabinet spaces, well, firstly, you don't have to buy more filing cabinets and paper, but importantly, it frees up floor space, and that could be used more productively. We know rent is expensive, or if you're the owner of the property, you could be renting it out, and having a whole range of cabinets is certainly not good use of floor space. And importantly, an EMR should be able to give you an accurate bill at the end of the process as a natural progression from documenting the clinical encounter. And of course, you can access it anywhere, anytime. Then, in terms of variabilizing costs, if you can't reduce costs, then maybe variabilize and make sure that your suppliers are aligned, or their costs are aligned with your revenue. Particularly with your technology partners like a health coach, make sure that they are charging a revenue percentage so that if your revenue gets hit, your costs aren't fixed and they go down too. Another consideration might be, because of sometimes a big disruption in your practice, this might be a time to consider a bureau. Again, they are typically linked to how much revenue is collected. So in low months, it will be low, the costs. An opportunity to maybe remove some fixed monthly costs from your business, and they typically have got very good bad debt collection strategies that would be good for you. And then lastly, and only if really necessary, consider bridging finance. Nedbank, for example, have got quite a good offering. They're offering up to 200,000 Rand overdraft facility at a really good interest rate, prime +1. With a bit of a holiday period, that might be something you want to consider. Of course, with banks, there's a lot of paperwork that needs to be filled in. They kind of need to know your aunt's shoe size before you are allocated any money, understandably so. There are other options, something we're working closely with another group where, based on your practice performance, both in terms of your revenue, traditional revenue flows, and how well the practice runs, there's a pre-approved and instant, within 24 hours, money that can be delivered into your bank account. Obviously, at a slightly higher interest rate, but if there's a real urgency, that can certainly be applied. So in conclusion, a couple of key takeaway points. We are navigating through the storm rather well, it seems, right now, particularly after last week's news. And looking at the numbers on a daily basis of late, I think we're doing well as a country overall. However, the impact of COVID-19 will be on the business of practices for a while to come. And it presents, I think, some real key financial risks, not just in the past, but in the next couple of months. The good news, though, is that hopefully we've shared with you some actionable strategies to mitigate these risks somewhat. And they really fall into two categories: ways to recoup revenue and ways to either reduce or variabilize the costs of your practice. And that's all I have on my side, except to leave you with a quote from Darwin, which apparently it wasn't Darwin, but certainly he takes credit for it. It's not the strongest, but the most adaptable that survive. It is a key mantra that we use at HealthBridge. And I think for all of us, for you as well, and for your practices, it's those adaptable that ultimately will survive and ultimately thrive out of this. So maybe we all need to reframe this tough time as an opportunity to get stronger so that we thrive going forward. I thank you very much for being with us. We're just a little bit over. Apologies for that. It's 8:06. But thank you so much for attending it. I hope that you got good value from the session today. Over to you, Liza. Any last minute?
Just to wrap things up, I'd like to ask that everyone completes the HPCSA evaluation form. I actually have popped the link into the chat box. And then, just to remember to please keep a lookout for an email that will be coming from webinar@healthbridge.coza. This email will contain your CPD certificate for download. And I know some of you have to jump off now, so if you're unable to fill out the form now, the email will also contain a link to the HPCSA evaluation form in there. Also, if you have any questions, please send them to webinar@healthbridge. We do have one last question that I thought everybody who needs to leave can leave, and we can stay and answer it. But otherwise, I hope everyone found tonight's topic interesting and insightful. And thank you from HealthBridge.
Thank you.
Great. So the final question that we have, and again around billing, again not too sure. Thank you for the educational presentation. I want to know, how does one bill for the Discovery COVID-19 event that is being introduced?
Yes, so we received a circular that there's yet another code. So Discovery came out over and above the 0130 code. They came out with some Beacon S, Beacon M codes and so on and so forth. We believe there will be another code that will come out that talks specifically about that package for COVID. I think I stand to be corrected. I think, Liza, once again, I know that Dia and Jared have got that code, but there is a specific code for that. There was a letter that was circulated, I think, last week from Discovery that spoke about that package. I think it's a 3,000 Rand COVID package. And in that letter, you should have received it. There was specific reference to that code, which, as of this week, in fact, should be in the price files of the PMA system that you use. I'm tempted to look for it a bit, but I don't want to waste people's time. But there is a new Discovery code for that.
Perfect. Great. Well, and then that sort of wraps us up for this evening. Thank you, everyone.
Awesome. Thank you.
Cheers.
Goodbye, everybody. Have a good evening. Keep warm.